So first of all, I'd like to say thank you very much for having me here. It's a pleasure to be able to speak on this topic, which has been something that's been really at the forefront of my mind since I've been working in colorectal surgery and colorectal care. And EDS is something that we are seeing more and more of in clinical practice, and something that I think really does require a specialist touch. So it's lovely to be able to speak at this summit and be able to discuss these topics, which I think are so important. So I'm going to cover dietary considerations for surgery, prolapse, and colorectal dysfunction. This is a topic I could spend hours talking about, so I'm going to keep it brief for you and try and stick to time. My name's Sophie Medlin. I'm a consultant colorectal dietitian, which basically just means I've been a dietitian here in England for a long time. I registered in 2007. I initially worked in elderly medicine, so head and neck cancer, nutrition support, and made my way into intestinal failure and colorectal surgery and diseases. From my NHS work, I moved into lecturing. So I was a lecturer at Plymouth University and then later at King's College in London. And I'm lucky enough to still do a lot of lecturing around the country now here in the UK. I set up my private practice as soon as I started in lecturing actually, and built that up gradually. And I've been running my clinic, which is City Dietitians, for about 7 years now. We have a team of highly specialist dietitians, and of course, I cover colorectal surgery and colorectal care. I also do media work and product development, developing probiotics and supplements and all sorts of interesting things, which means that my life is busy, but always very interesting. I'm going to talk about the types of EDS and their associated colorectal complications, common colorectal issues experienced by our EDS patients, nutritional considerations for surgery, management of colorectal problems in EDS, escalating care, so what to do when you're not sure what to do, and communication skills for colorectal care. One of the reasons that I'm so passionate about working with colorectal patients, and it's the same for my EDS patients as well, is that I feel we can make such a big difference to people's quality of life. And bowel problems can be so debilitating and cause so many emotional problems, social problems, all sorts of issues to people. And being able to support people to resolve those issues, or at least hopefully improve those issues, is such a wonderful thing to be able to do. I feel so privileged to be able to support people in that way, and support them to get their life back, to be able to not be tied to the toilet all day, and to be able to go out for meals with friends with feeling less anxious, and all those things that really improve one's quality of life. So it really is an area of passion for me to work with these patients. And some of my friends and family and people who are not in the healthcare space find it very odd that I'm so passionate about talking about poo, but it genuinely is something that makes me happy and proud and fulfilled every day. So when we think about EDS, the main reason that people struggle or can struggle so much with their colorectal structure and function is because of the hypermobility. And we know from EDS and how it affects other organ systems and people's day-to-day lives, is that the structure and function of the connective tissue is just not as rigid or as reliable as those who don't live with EDS. And that can mean that both obviously connective tissues within the joints and things like that, but also within the rectum and places that we don't see are hugely affected by that hypermobility. We don't think about it unless we have to think about it. But the evacuation of stool, or the effective evacuation of stool, does rely on very carefully coordinated and timed tension and releasing and relaxing of connective tissues throughout the rectum and the anus. And one of the big problems that we see in EDS is rectal prolapse, or general pelvic organ prolapse. And that, of course, then creates problems with the evacuation of stool. If you look at the diagram on the left-hand side at the bottom, that would be what we would consider to be normal anatomy. So you can see that the passage that the stool needs to evacuate from through the anus is actually quite open. It's much larger than it is on that right-hand side where that rectal prolapse has occurred. So where rectal prolapse does occur, the passage for the stool to pass through becomes much more narrow. And that means that stool can get very stuck, can be very difficult to pass stool, and patients can be incredibly uncomfortable. And they'll report that in many different ways. They may report that they are aware they have some sort of prolapse, but more commonly, they'll say that they are trying to pass stool, but nothing will come. They know they need to go to the toilet, but they can't pass any stool. And this can, of course, cause lots of pain and problems with the stool becoming harder and more difficult to pass in the end. The harder and more difficult to pass and bulkier the stool is, the more difficult it's going to be for that passage through that narrower rectal space. So we really have to work on the consistency of the stool with patients, reducing the need for straining so that the prolapse doesn't continue to occur, and support them to keep well hydrated, keep up with good movement and healthy movement for them, whatever that might look like, given their other physical disabilities that may potentially be there. But I think my key point really here is that we just don't. One of the things I say to my patients and other people is, everyone takes their rectum for granted until it goes wrong, and it really is as complex as the swallowing coordination that is required. So closing of valves, opening of other valves, and allowing things to happen. And if it's not working properly, it can obviously be a significant burden to people in terms of symptoms. Always we think about hypermobility, and those evacuator issues, as I mentioned, will be reported. And the key thing that I would say to you as clinicians and perhaps people who live with these conditions is that if people are reporting that the stool is soft but difficult to pass, we really shouldn't be treating that as normal constipation and telling people to eat lots more fibre, because it won't work. If that stool is bulkier, full of skins and peels and pips, things that don't get digested higher up in the digestive tract, as you can see from this picture, where we've got that narrower rectal passage for it to pass through, it's going to be more difficult for the patients, not make it easier. But unfortunately, lots of these patients will have been told to treat it as typical constipation to start with, and generally and genuinely that makes it a lot worse. So patients will generally report that stool is soft but difficult to pass. They might report tenesmus, which is a feeling of needing to go to the toilet without being able to go to the toilet. And that's generally because the stool is a bit trapped and those nerves and things are being stimulated. Of course, we know in EDS that lots of people have hypersensitivity to the nerves throughout their digestive tract, and that includes in the rectum and anus. So it can be quite difficult to differentiate how much is actually the genuine need to pass stool because there is stool there, and how much is that hypersensitivity. But in general, it will be that reported hypersensitivity, that feeling of needing to go but being unable to. People will experience that toileting takes a long time. They may feel they need to strain, which of course in the case of a prolapse will make things worse. Or it will be that the patient is requiring to go to the toilet multiple times. I would call it clustering. So generally the question I would ask would be, is it that you need to go to the toilet in the morning, you have your bowels open a little bit, but then you have to go back over and over again? That's a clear sign of evacuatory issues. So not having a complete evacuation at the first time that you visit the toilet. And, you know, a small amount of that is normal. Having to go back one more time, twice again, fine. But when it becomes the case that people are reporting that they can't leave the house until they know that everything's passed, they have to get up extra early to try and go to the toilet 7, 8 times before they can leave the house, that's when we know we've got a real issue there. So the other thing that can happen commonly in patients with EDS is other diverticular disease, which is where we get these small pockets of connective tissue where it's sort of perforated through. It's not gone through the bowel wall necessarily, it can do, but where it's sort of bulged out between the connective tissue, rings of connective tissue. They're called donuts of cartilage through the colon. And this is more likely to occur, of course, for every other reason that these problems occur in EDS patients, because of that hypermobility. The tissue structures are different and are struggling to maintain their integrity. This should be treated the same way as other colorectal complications. And importantly, patients with EDS and diverticular disease are more likely to have a perforation because, of course, the tissues are even more fragile than in someone who doesn't have EDS. And for that reason, we do need to treat this carefully and consider everything carefully. One of the things that I find interesting is that I'm finding that a lot of my diverticular patients, particularly those who are presenting younger, probably have a connective tissue problem too. And the way that I would ask them that is to say, have you had a lot of issues with spraining your ankle or breaking or stretching ligaments and causing problems to joints? And they'll often say, yeah, I do have that. And so I think that this is probably going under the radar in terms of this connection between diverticular disease and other connective tissue problems a lot of the time. One of the things that's really important to note is that, of course, we have lots of different types of EDS, and vascular EDS is one of our highest risk patient groups. Of course, EDS with vascular problems poses a risk of GI bleeding and perforation because of aneurysms within the gut. And specialist care is really advised for these vascular EDS patients, especially if they are reporting bowel issues. If incorrectly advised, so for example, they're told to eat loads and loads of fibre, or treat things as normal constipation, take lots of laxatives, for example, then this perforation's life-threatening complications are more likely, and we do need to be aware of that and treat it with the greatest of care. If our patients with EDS are going for colorectal surgery, which happens frequently, lots of my patients may have had an ileostomy, so a stoma, because of their difficulty with evacuation. They could have a colostomy, most likely it will be an ileostomy. They may have to have parts of their bowel resected because of blockages and things like that. Careful preoperative nutrition is really important in these patients, as well as postoperative care. So we know that wound healing is an issue in EDS. So we want to really optimize the protein intake, the vitamin C intake, and zinc. Those three are very closely associated with tissue healing and recovery. So the zinc and the vitamin C help with collagen formation and the reformation of tissues. We obviously want to make sure that they are iron replete. And so our patients should have their iron checked before surgery, and they will have an infusion if needed. But iron and B12 are also really important for preoperative support, because those products are lost a lot in surgery. And of course, we want to aim for a healthy weight. And, you know, ideally, we want people to have a bit of weight to lose before they go to surgery, actually. And the reason for that is because we know they're going to lose weight postoperatively, and postoperative outcomes are closely associated with being underweight. So if you're underweight, you're more at risk of things like pneumonia, poor wound healing, all of these things that we really want to support our EDS patients in preventing, and all patients really, before they go into surgery. Post-operatively, patients need to try and return to appropriate nutrition, either oral nutrition support or artificial nutrition support quickly, again, to support that wound healing and get things moving much more quickly for them. In a post-operative period after bowel surgery, all patients are at risk of something called an ileus, where the bowel sort of falls asleep for a while and doesn't move at all. EDS patients are likely, although I don't think there's any research on it, more likely to have an ileus for a longer period, because it relies on that connective tissue to be able to move everything through the bowel properly. And so in that case, patients should be receiving intravenous nutrition support, again, early, to support their recovery. Adhesions are scar tissue that forms either sometimes behind the scar, where the bowel sticks to the scar at the front of the body, or it can be that bowel sticks to other bits of bowel. And unfortunately, these adhesions are more likely to form in patients with EDS. So if you have patients, or you are a patient who reports that sometimes things feel very uncomfortable in their tummy, they can get quite bloated and distended, we would call it. Tummy feels hard, and then maybe suddenly they have a rush of stool coming through, or they have to really massage things and take it easy, then those would be signs of adhesions and blockages, small strictures potentially in the bowel. And that's because typically the bowel, particularly the small bowel, moves very freely within the abdominal tract, so it will allow a bolus of food to move through quite easily. Whereas if it's stuck down, for example, if this section is stuck to the bowel wall and a bolus of food is coming through here, it has to turn a very tight corner to get around that, and that's where things can get a bit stuck and trapped for people. And that sort of feeling of bloating and the stool pattern that occurs with that, we need to have the skills and expertise to be able to differentiate that from, let's say, standard bloating and IBS type symptoms. And that's not necessarily the case for all clinicians. In terms of nutritional management of these patients, we want to be remembering that everybody is really different, and providing the right support at the right time is really important. Experience is really key, because, again, we need to really listen to these symptoms and be able to differentiate them from other symptoms. What I recommend for a lot of my patients is to reduce the insoluble fiber, so skins, peels, pips, nuts, things that build up in the digestive tract and aren't easily digested. They are going to become more stuck and create more problems for people in this situation. And of course, people will potentially have seen their GP. They may have seen other nutrition professionals who've told them to really increase their fiber. So often this is going against the advice that they may have received previously, which requires trust in the clinician to go against that advice, but also knowing that they are going to massively increase fiber in another area. So we really want to optimize the soluble fiber. So things like smoothies and vegetable soups are so useful. Root vegetables are great. Things like melon, tinned peaches, things that are soft and easy to digest are ideal for these patients. And that's not to say that people should be pureeing all their fruits and vegetables or only having mashed fruits and vegetables. Things like the heads of broccoli are great, heads of cauliflower are great. I generally would say anything that would easily push through a sieve with the back of a spoon, perfect. Things that collect in the bottom of the dishwasher, not ideal. And I would sometimes also say, if you imagine if you had a slightly blocked kitchen sink and you were thinking, oh, I don't know if I should wash this down there, those are the things that we want to be a bit careful with. I would also consider soluble fiber supplementation, and that might be in the form of products, depending on how debilitated the patient is elsewhere. So it could be things like we would use fibrogel in this country. We would use other sort of formulated supplements of fiber, soluble fiber, or more commonly, I would recommend psyllium husk, possibly even ground chia seeds that have been soaked. But it's really patient dependent. And if someone is debilitated, then buying powders and making these things themselves can be quite difficult. So the pre-made soluble fiber supplements can be much more useful. Obviously, we want to optimize hydration. And toileting position is something that all of us as nutrition professionals can be advising our patients on safely. So it's about trying to get your feet up on a stool. And the reason for that is this puborectalis muscle chokes the rectum when we're not in the right position, but really helps to release it when we are in the right position. So when we're squatting. And I think one of the things that we sort of forget is that, particularly in people who are shorter, most toilets are too high for them. So giving this advice, and I'll ask my patients, how tall are you? I usually would have asked them in my rest of my nutrition assessment. If they tell me they're under about 5 foot or around 5 foot, I would say definitely think about a toileting stool. If they're a tall man or a tall person, then generally they might be in the right position on the toilet. If it's the case that somebody has a rectocele, where there's a bulge into the vagina from the rectum, then rectocele tools can be really useful. And that is something which you insert into the vagina. It's a bit like a shoehorn, not very glamorous. Insert it into the vagina and gently push back, and that will resolve the rectocele and allow the passage of stool to be much more comfortable for people. If it's the case that your solutions, the things that you're offering, or the normal constipation treatments that you offer are not working, it's not simple constipation. So people who have simple constipation increase their fiber intake, they increase their water intake, they do a bit more walking, and the bowel works much better and the constipation is resolved. If it doesn't resolve with simple solutions, it's not a simple problem. And again, if you've exhausted your toolkit or you feel out of your depth, do refer to a specialist colorectal dietitian. We see these kinds of patients all the time. The other thing that's really useful is and I regularly refer to pelvic physio for biofeedback, for pelvic floor exploration, and also training, which can make a massive difference to people's general health. And the pelvic floor, as we know, sits underneath. And I was having a conversation just this week with a patient, and I said, I think you need pelvic physio. It's to do with your pelvic floor. And she said, well, I didn't know your pelvic floor affected your bowels as well, but it massively has a huge impact on bowel function. And so if people are struggling with urinary continence or not, then bowel function and pelvic floor are very closely linked. So really important to remember that. One of the things that I think is really important to consider is your communication skills when you're talking about these issues. So it can be a very uncomfortable topic for some patients. Some patients are very comfortable and used to talking about these things. Others will not be. So I think it's helpful to remind them that the more you know, so the more they are able to tell you, the more you can help. I always reassure my patients that I talk about this all the time, and I know it's uncomfortable for them, but this is what I'm here for. When I can see that the patient is really uncomfortable talking about this topic, I will say, I'm going to ask you some more uncomfortable questions about your poo. I know it's uncomfortable, but it's going to really help me to make a diagnosis and give you the right treatment. And incontinence is a real issue and a real possibility in these patients. So the really important thing to ask is, can I ask you if you've ever had any accidents, or do you worry about incontinence? Do you worry about not being able to make it to the toilet on time? Not always will these patients disclose that this is an issue for them. And so it's really important to ask that question directly and to get the answer that you're looking for. Nobody needs to live with fecal incontinence, despite what people might tell them elsewhere. It's something that can be supported and helped, and it's not something that people should be living in fear of every day. Thank you so much for your attention, and I will look forward to answering some of your questions later.